My name is Dr. Raju. I'm one of the fellows sponsored by Cardiac Risk in the Young, and I'm going to be talking about the QT interval in athletes and hopefully address the question, how long is too long? I'll start by going into the basics of the QT interval and just reiterating exactly why it is important. I'll talk a little bit about the current guidance that's available and the evidence on athletes and the general population in terms of evaluation. Speak about the pitfalls in diagnosis, and then I'll go on finally to talk about something that I'm sure you've appreciated as a special interest of our own group, and that is physiological changes in ethnicity in athletes, and talk about the QT interval in black athletes at the end. We've been talking all morning about pre-participation evaluation and using that as a tool to identify and differentiate between physiology and pathology, and thereby address risk stratification and reduce the risk of sudden death. And there are two documents published within the last couple of years that go to talking about the 12-lead ECG and its importance in pre-participation evaluation. On the left at the bottom there is the European Sports Consensus document that was published last year, and then a more recent from earlier this year, an independent working group special report published in Circulation, which again addresses the ECG. So why are we interested in the QT interval? Well, because it is known to be a marker of the congenital long QT syndrome, to which it gives its name. The congenital long QT syndrome is a genetic or an inherited disease of primarily sodium and potassium cardiac ion channels, and it predisposes those affected to torsade de pointes and potentially cardiac arrest that is largely exertional in most types. This can present with either syncope, which can mimic seizures, cardiac arrest, or sudden death, depending on whether this arrhythmia is self-terminating, whether the patient is cardioverted or not. Down at the bottom here, I have an image of an implantable cardioverter defibrillator trace from a patient with long QT syndrome who, at the bottom left, is in sinus rhythm, has an early coupled ventricular ectopic, which puts them into torsades and subsequently into VF. I assure you that this patient survived following appropriate recognition and treatment by the defibrillator. I will just mention briefly at this stage that prolongation of the QT interval is also seen in any kind of cardiac pathology, and so it's important to exclude other cardiac diseases as well, even in the context of a long QT. So, returning to basics, and it'll be clear why I'm doing this. The QT interval largely represents duration of repolarization of the myocardium in a single cycle, and at this stage I'll reiterate that it needs to be corrected for heart rate because it does vary with heart rate. The Bazitz formula has been used since the 1920s, and while there are more recent variations that are available to correct for heart rate, the Bazitz is certainly still the most widely applied and well established, and the formula is given there as QT divided by the square root of the RR interval in seconds. I like using this picture on the right here, which demonstrates the QT interval on a diagrammatic representation of a single cardiac cycle, and it seems pretty straightforward that the QT interval starts at the initial onset of the QRS and ends at the end of the T wave where it intersects with the isoelectric line. Unfortunately, reality is not quite so simple. This is a study by Viskin, which quite simply selected 4 ECGs, 2 of which were patients with the congenital long QT syndrome in the top 2 charts, and 2 of which were control or normal ECGs in the bottom 2 charts. And these were shown to 25 international QT experts, a little over 100 arrhythmia experts, 300 general cardiologists, and 400 other largely general physicians. And I'd like to just go over these to show that the gold standard, or the QT experts in the bright red, in all of these, shows very little variation in each of these, perhaps plus or minus 10, maybe plus or minus 20 milliseconds. Arrhythmia experts in green largely agreed with a slightly bigger spread in measurement of the QTC. And I have to pause and apologise to my colleagues in the audience here, where general cardiologists unfortunately perform no better than general physicians, and rather abysmally overall, with, as you can see, the red and blue lines here for everyone else shows a almost indistinguishable range of QTC measurements between those in the top graph, which are congenital QT patients, and the bottom, which are supposedly normal. This isn't very reassuring, is it? And the question is, why is this? Well, there are a number of difficulties that haven't yet been mentioned. The first is QT dispersion, and this essentially describes the variation in QT interval depending on which of the 12 leads is used to measure it. So that's the first concern. The second is that the U wave can often complicate determining exactly where it is that your QT interval ends, and this can equally be confused with notching of the T wave. I mentioned Bazitz correction, and there are some limitations to its use, partly because of its underestimation with bradycardia and its overestimation with tachycardia, but it is commonly used, and it's also the formula that's used by most automated computer measurements. Automated computer measurements of QT interval are recognized to be flawed. However, if on your ECG the absolute QT is correct, then at least you can rely on a computer to calculate your corrected QT accurately, which is not necessarily the case with people. A follow-on study for that which I presented on the previous slide showed that in order to improve reproducibility of QT measurements, the teach the tangent rule was applied, and this was actually taught to students, medical students essentially, and rather shamefully again for all of us here, that medical students did better than both arrhythmia specialists and general cardiologists and everybody else in comparison with international QT experts when using this method. So I just want to go over this in case you haven't seen this before. The end of the QT interval, or the end of the T wave, is determined by the intersection of the isoelectric line with the maximal downslope, or the tangent, from the T wave. Same again here. And you'll see in the left-hand picture that this excludes the final tail of the T wave, and in the second picture it excludes the U wave, and this is reproducible. So moving on to the topic at hand, the QT interval in athletes. Well, as we've already demonstrated by that previous slide, that there are difficulties in determining what it is. In athletes, it's yet more difficult because, as we know, sinus bradycardia is more common, and as I said, this is under-corrected for by Bazitz. Sinus arrhythmia poses a particular problem, and again, athletes tend to have a more marked sinus arrhythmia. As to how to measure the QT interval in these situations, there are various recommendations, some of which suggest you should use the shortest RR interval, or somewhere which suggests you should use the longest RR interval on an ECG. But the most applicable and perhaps the best way would be to average the corrected QT over a 10-second ECG, which is unfortunately somewhat time-consuming. Most importantly, perhaps certainly from the athlete's or the patient's viewpoint, is the impact on their career, that is, with regard to potential false diagnoses and premature disqualification from competitive sports. But the question requires an answer, and certainly these two documents that I mentioned, the ESC guidance from 2010 and this more recent circulation paper in 2011, recommend thresholds of 440 milliseconds in men by the Europeans and 470 milliseconds by the more recent circulation paper, and in women 460 milliseconds and in the circulation paper 480 milliseconds. These are essentially suggested by a consensus group, and that is based on expertise of these individuals. The grey zone has been mentioned with regard to physiological adaptation in a number of lectures earlier, and this also applies to the QT interval. Our own work by Bazitz Formula some years ago suggested that any QT interval under 500 milliseconds should be considered within the grey zone, and I'll go on to explain why that is. In the general population, why do we have a grey zone at all? And not just in athletes is there an overlap between normal and the long QT syndrome. You'll see in this graph on the right-hand side, the dashed line indicates a long QT syndrome population, and these three peaks on the left are various different control populations of different age and gender. Irrespective of which of those is selected, and almost irrespective of where your threshold is kept, there will always be an overlap of anything between about 1 and 15%, where that's the prevalence in a normal control population. And unfortunately, 25% of people who have a long QT syndrome are seen to have a normal or so-called normal QT interval. And hence, while it's named long QT syndrome, the diagnosis of this condition is somewhat more complex and requires a scoring system that includes not just ECG characteristics, that is, measurement of the QT interval, but also T-wave morphology, personal symptoms such as syncope, and family history of either the long QT syndrome or premature sudden death. Increasingly, genetic mutation analysis is proving to be a useful adjunct as well, with about 3/4 identified with a definite mutation of those who are known to suffer with the long QT syndrome. So, what do we do in the grey zone? Well, firstly, as mentioned earlier, it's important to exclude other cardiac pathology, but in terms of personal history, a medication history is important with regard to identifying acquired QT prolongation, symptoms, as mentioned, specifically with regard to syncope, a family history of premature sudden death or the long QT syndrome, or epilepsy or recurrent syncope, which can direct you towards a possible familial component. These individuals who fall within the grey zone are recommended to have further investigations in order to identify whether they genuinely have evidence of the phenotype, and this can be done with 24-hour or nocturnal QT measurement, provocation testing by a variety of methods, either by exercise, by adrenaline or epinephrine infusions, or by postural provocation, which is a more recent idea, where an ECG, a continuous ECG recording from 5 minutes of lying at rest to stand immediately or post-standing, can potentially identify those with a specific type of the long QT syndrome. However, these investigations are not without their own flaws as well, and certainly a normal range for the nocturnal QT interval is somewhat difficult to come by. This is a paper from 2006 in a normal population, which shows that your nocturnal QT interval, whether in men or with women, is perhaps 20 to 40 milliseconds longer than in the daytime, and hence the thresholds that we apply to daytime ECGs may not apply to 24-hour monitoring. This is an example of provocation testing with exercise stress, and this is actually a 9-minute rest or recovery ECG following exercise, which shows from left to right heart rate reducing from about 100 beats per minute down to 60 beats per minute. And you'll see, hopefully just by visual estimation, the delayed QT adaptation with a relatively prolonged QT interval remaining as the heart rate slows. All of these tests obviously have a predictive value dependent on their pre-test probability, and overall in the general population, the prevalence of the long QT syndrome is felt to be of the order of 1 in 2,500. However, because of the problems of incomplete penetrance, this can be difficult to estimate. Despite this, on the basis of our knowledge of the long QT syndrome, this gives any individual with a QTC measurement above 480 milliseconds just a 4% likelihood of having the condition. In athletes, there's two sets of data, our own data, where 2,000 elite national or international competitive athletes were assessed, 7 of whom were determined to have a corrected QT above 460 milliseconds, which represents just 0.4%. of whom 3, so that's just under half, were finally determined to have evidence of the phenotype and/or genetic mutation analysis. And most importantly, this is where the grey zone up to 500 milliseconds has been determined, where all of those with a resting QTC above 500 milliseconds were determined to have the condition, while none of those in the grey zone were fulfilled definite diagnostic criteria. I will mention from Professor Corrado, who's here, his paper from 2006, which described over 40,000 screened athletes, and while no specifics are mentioned, 5 of them, so that's less than 1 in 10,000, were ultimately disqualified from competitive participation in sports because of a diagnosis of long QT syndrome. I want to move on to our special interest of ethnicity. As was described beautifully earlier this morning, African and Afro-Caribbean or black athletes have a higher prevalence of a number of repolarization changes, including ST elevation, early repolarization, and T-wave inversions, all of which are associated with QT changes, certainly in the context of pathological processes which cause these electrocardiographic changes. And similarly, they have a higher left ventricular wall thickness or mass. In terms of the congenital long QT syndrome, they have black patients have a similar clinical course in the congenital long QT syndromes, although while I recognize the numbers here are quite small, 41 African Americans in comparison to over 3,000 Caucasians from a US registry, the QTC is longer in those affected. So we studied elite athletes from multiple disciplines and showed in male athletes that the mean QTC is lower in black athletes, albeit with a wider variance, despite, as expected, finding that there are higher proportion of ST segment elevation, T-wave inversions, and a higher mean LV wall thickness, although this did show a similar prevalence of prolongation of the QT interval where 440 milliseconds was used. Similar findings in female athletes, albeit with a smaller number, that is 123 black females, showed that there was no actual significant difference in mean QTC by ethnicity. And again, with a similar proportion with a prolonged QTC. So I'll return back to our initial question, how long is too long? And this is going back to the money slide. These greater minds than mine have put their heads together and come up with these suggested thresholds for abnormality. But I'd like to respectfully suggest that perhaps it's the wrong question. And more importantly, it'd be important to ask, how is it measured, and perhaps even by whom? And furthermore, certainly in the general population, if 480 milliseconds, which is certainly an upper threshold for most, is used as a sole diagnostic indicator, it's likely that about 20 people will be falsely diagnosed for every true diagnosis. So I'll summarize by saying QT prolongation is certainly a marker for the long QT syndrome, but is not solely sufficient to make a diagnosis, which should be made probably by an expert and in the context of not just the ECG but additional investigations. And from our own data, there's certainly no ethnicity-specific QT threshold that's necessary. Thank you very much for your time.
Thank you very much for the nice lecture. Can I ask you from a practical point of view? So you've got an athlete who's got a QT duration of 490 milliseconds. What would you do?
As I mentioned, it's important to take firstly to exclude other cardiac pathology with investigations that were described in pre-participation evaluation talks earlier. But if all other investigations are normal, then specifically looking for evidence of the long QT syndrome, a treadmill test to look for either inappropriate prolongation during the test or early in recovery can point either to the long QT1 or long QT2 phenotypes. Nocturnal monitoring, as I mentioned, it's difficult to come up with absolute thresholds to make a diagnosis, but if there is significant prolongation overnight, that does point towards a possible diagnosis of the long QT3 syndrome. Other tests, as mentioned, could be lying and standing ECGs, epinephrine tests, but perhaps even more importantly than that, taking a family history and a careful family history, and if possible, inviting other family members to be evaluated at the very least with a baseline ECG to see whether there is any familial phenotype at all. If, despite all of these investigations, you don't fulfill diagnostic criteria and it's not felt that there is any role for genetic testing in the absence of a definite phenotype or familial testing, then the best advice is to not give somebody a diagnosis, given that the likelihood, the balance of probability at 490 milliseconds is actually they don't have the long QT syndrome per se, but it would be useful to keep those people under review because your QT interval can and does usually increase with age.